Next speaker is me. I'm going to discuss something unrelated to EGFR. Well, not completely. I'm going to address actually a couple of the questions that have come up, but specifically look at angiogenesis and non-small cell. There was a time, maybe 8 or 10 years ago, where that talk would have been 2 or 3 talks about angiogenesis, and the tables have turned. Now we have 3 talks for EGFR and 1 for angiogenesis, but it's still an important topic. So I call this the reemerging role of angio inhibition in the management of non-small cell in 2016. Since the approval of Bevacizumab, it's become really a mainstay of our therapies. My disclosures over the past 8 years. The angiogenic switch is present really fairly early on. Smaller tumors are generally non-vascular and fairly dormant, but once that angiogenic switch turns on, the tumors become vascular and the metastatic potential of those tumors goes up, and that continues through the lifespan of the tumor. VEGF is a logical target. It is the predominant mediator of angiogenesis throughout the development of many tumor types. We see additional factors that sort of join the cascade, become secondary angiogenic pathways, but VEGF is there from the get-go, and this is pretty much true of all solid tumors. So hence the use of these agents across the board in solid tumor oncology. There are 3 basic approaches. We have anti-ligand blocking antibodies such as Bevacizumab, so targeting the ligand, not the actual receptor. In contrast, Ramucirumab targets the receptor, and I'll show you data for both, obviously. And then thirdly, the non-antibodies, the TKIs, oral agents that target the tyrosine kinase, so work on the domain within the receptor that leads to activation within the endothelial cell. So Bev was the first out of the starting block, recombinant immunized monoclonal IgG1 antibody that recognizes all isoforms of VEGF-A and blocks VEGF function. Its half-life is about 3 weeks, which dovetails very nicely with our standard chemotherapy regimens, which are generally also given essentially every 3 weeks. Initially, early on, it leads to regression of existing tumor microvasculature and normalization of the remaining tumor vasculature, and then over time, the inhibition of new tumor vasculature. And of course, without vasculature, the tumors cannot survive. Eventually, they can die off. They're not getting their nutrition. And there is certainly preclinical data to suggest synergy with standard cytotoxics, particularly the taxanes. So the first study to really put Bevacizumab on the thoracic map was this randomized phase 2, and I had the privilege of being part of this effort back in the early part of the new millennium when I was still at Fox Chase. This looked at Bevacizumab at 2 different doses, either 7.5 or 15 mg per kg every 3 weeks, in combination with standard PAC carbo, with a control arm of PAC carbo alone. And note there was crossover at the time of disease progression to single-agent Bev in that control arm. Well, this trial is the reason we don't give it to squamous cell. There were 6 cases of severe or fatal pulmonary hemorrhage. 4 out of 13 individuals with squamous cell suffered this. That's over 30%. In contrast, only 2 out of 53 with non-squamous histology had severe pulmonary bleeding. Those on the chemo-only arm had no such episodes, and it was really based on this analysis, small numbers but a major safety signal, that squamous histology was identified as a risk factor for pulmonary hemorrhage and has been forever since excluded in clinical trials looking at Bev in this setting. The same trial did show some promising outcomes. If we look at the non-squamous population, very limited numbers, about 80 individuals, and you pool the 2 Bevacizumab doses, you see a median survival here of a year and a half, essentially, 76 weeks, compared to 53 weeks for the control group. That laid the groundwork for ECOG 4599. I'm sure several of you were involved with this study, certainly Phil, who you'll hear shortly from, and myself. We accrued quite a few individuals. This study had a life of its own. Every month the accrual went up. basically isolating the role of bevacizumab in the context of frontline treatment. And you got to remember, up until this point, we had gone about 10 years without any positive trials whatsoever. So it was PAC carbo alone, plus or minus bev, non-squamous, no history of antecedent hemoptysis, no history of CNS metastases, and you can see in the bottom right that it scored on every endpoint. We see a significant improvement in response rate, progression-free, and overall survival. And for the first time, we had pierced that 1-year barrier for median survival, and we were seeing over a 20% 2-year survival, which was really unprecedented in our experience in non-small cell. So here are the curves. Again, pretty impressive p-values. The hazard ratio for OS was below 0.8. But still adverse events, even with the elimination of squamous histology. You see more than a 4-fold increase in grade 3 or higher hemorrhage, nearly a 5-fold increase in pulmonary hemorrhage, hypertension, exacerbation of both neutropenia and febrile neutropenia, and there were 15 deaths on the Bev arm compared to only 2 in the control. So it was a bit of a concern, nearly 4% treatment-related fatalities, but including these individuals, we still observed a survival advantage. Now, again, when I was at Fox Chase, we went through our the patients we had seen in the preceding 2 years and tried to determine who would have even been eligible for this trial. And you can see about 2/3 or so would never have made it onto the trial because of squamous histology, brain mets, ongoing anticoagulation, hemoptysis, or poor performance status. But over time, we've whittled away at the exclusions. The Passport trial showed that it was safe and feasible and perhaps effective in those with brain metastasis, and the AVAIL trial showed that you could give folks bevacizumab even in the face of ongoing anticoagulation. So probably about half our patients up front are candidates. If you look at the numbers in AVAIL, about 10% ultimately received anticoagulation. I think probably 20%, 25% of our patients have some sort of thromboembolic disease and can still get these drugs as long as they're not life-threatening emboli. And in Passport, there was no evidence of undue toxicity in those receiving BEV, either after whole brain or stereotactic or neurosurgery. And here are the data from Passport that were published 7 years ago by Mark Szynski, showing that BEV could be combined safely upfront or even in the second-line setting with standard agents of the era. And out of 106 individuals, there were no CNS hemorrhages, grade 2 or worse, and really very little in the way of any CNS events. There was also concern early on that perhaps this agent didn't work all that well in women. When we looked at the initial data, the survival advantage didn't seem to be quite so pronounced. Heather Wakely later mounted an analysis looking at both age and gender, and you can see men across the board, shown in green on the bottom, had a survival advantage with bevacizumab, and in fact, women did too, at least up to the age of 60. Above 60, women were doing reasonably well on the control arm, and in fact, there was no advantage there. And it does give me a little bit of pause when I'm seeing a 70 or 75-year-old who would otherwise be eligible. Is it really worth it? Again, this is a post hoc analysis. It wasn't established as part of the initial trial. We also did another analysis looking at age. This is actually a joint analysis of ECOG 4599 as well as the Point Break trial, and in this case, pooling the PAC carbo bev arms and comparing them to the control arm that was used in 4599 with PAC carbo alone. So B is 4599. The A groups are the combined pooled analysis. And regardless, you see up to the age of 75, a survival advantage with everything to the left of unity on the forest plots. At 75 and older, that survival benefit seems to be lost. And here are the curves. So under 75, about a 3-month improvement in overall survival. Above 75, no significant improvement. That hazard ratio jumps from 0.78 to 1.05. And again, I think many of us have some qualms about using these agents, and certainly older individuals, even if they appear to be quite fit. Here are the phase 3 trials. AVAIL and JO 19907 showed both response and PFS benefits, but no survival benefit. I think over time there was a trend toward using this agent less and less. But many of you are not aware of the Beyond trial. It was essentially a duplicate of the 4599 trial, but conducted in China. And if you look at the data there, significant improvement in response rate, about a 3.5-month improvement in PFS, and a nearly 6.5-month improvement in overall survival. So confirmatory data from another part of the globe, again with a taxane backbone. This was published in JCO just last year. I dare say probably most of you are not aware of these data. By Keikon Zhou, is the deputy editor of the ISLAC News. It's a little bit hard to see, but the baseline demographics are shown here, and both arms are well balanced. You can see there's about a 50-50 split in smokers versus non-smokers. And this trial included EGFR mutants who had been previously treated with TKIs. About a quarter of the patients fell into that category. And PFS curves separate very early on at about 3 to 4 months. And in the forest plots, you see a benefit regardless of age, gender, performance status, smoking status, stage, or whether they had prior curative intent surgery. And the overall survival curves likewise separated about 8 to 10 months, and that separation persists over time. So I consider this trial from China validation of Bevacizumab's utility in advanced disease. And remember, this is the group that doesn't have PD-L1 positivity necessarily up front and may or may not have already been treated with the TKI. Is there a role for maintenance Bev, Bev and PEM in combination? We have no individualized, prospective, randomized phase 3 trial that actually isolates the role of Bevacizumab as maintenance therapy. What we do have is a landmark analysis from 4599. So these are the individuals who went through their 6 cycles of chemotherapy with or without Bev and were ready and did not have disease progression. So on the right are those who went on to Bev maintenance. On the middle column are those who were non-progressors with chemo alone. And you see in this landmark analysis significant improvements for both PFS and overall survival for those who are getting Bev maintenance from that point onward, with hazard ratios 0.64 and 0.75 respectively. So here are the, here's the PFS curve. You note until 4.5 months, everybody's progression-free. Advantage for Bev in that maintenance setting. And the same holds true for survival, and it actually separates a bit over time with a p-value of 0.03. Those are the only data that I'm aware of. Is combination Bev and PEM superior to Bev alone? Well, this is the AVAPEARL trial from Europe. Frontline treatment with cisplatin, pemetrexed in combination with bevacizumab for 4 cycles, and then the absence of disease progression, randomization to maintenance therapy, continuation maintenance with Bev, or continuation with Bev and PEM grafted onto bevacizumab. So 2 versus 1 drug. You see about 2/3 of patients actually went on to that randomization. Both arms were well balanced. By definition, all were non-squamous. You see about a quarter or so were never smokers. And certainly PFS benefited, about a 3.6-month improvement in progression-free survival, with pretty laudable hazard ratio of 0.5, p-value under 0.001. And if you look at it from randomization, it's 7.4 versus 3.7 months. So it actually doubles from the point they complete the cisplatin-based treatment. And you see some separation in survival with a hazard ratio of 0.75, but it is not statistically significant. I got to reemphasize that. The p-value here is 0.23. And the reason for this, I suspect, is the small numbers. This is really underpowered for survival analysis. Perhaps if we had maintained those numbers with 800, 900, or 1,000 patients, that survival benefit would have been observed. Many of us here in the US prefer a carbo-based regimen. This is a very popular combo, certainly used in our center and throughout the country. It originated in Phil's neck of the woods in Chicago. Some of us call it the Patel-Hensing regimen. Carbo-PEM-BEV for 6 cycles and then PEM-BEV maintenance. The phase 2 data were fairly promising with response rates over 50%, median survival of about 14 months. And that led to the Point Break trial, a direct comparison of PAC Carbo-BEV to PEM Carbo-BEV. So there are actually two separate variables here, not just the nature of the partner agent with platinum and Bev, but also the maintenance regimen. In the control arm, it was Bev alone. In the investigational arm, it was the combination. You can see that here. Overall, no significant difference. Median survival exceeding a year for both. 2-year survival rates, again, more than 20%, about a 3% difference for PEM. So essentially equivalent. And if you are a bean counter and look at the cost of PEM and Bev and carbo versus PAC carbo Bev, obviously you put the beans in a pile, the costs are going to be a lot less for the carbo PAC Bev combo since 2 out of the 3 drugs are generic. On the other hand, when we look at toxicity, there's really no comparison from my standpoint. There's minimal hair loss, little neurotoxicity, far less myalgias and arthralgias. So in that regard, the edge, I think, goes to pemetrexed, and certainly the patients generally feel reasonably good on this combination for the most part. Now, they also did a landmark analysis, again, in those who had not had disease progression. And you see about a 2-month difference favoring the PEM carbo Bev arm, both for progression-free and overall survival. Note there are no p-values or hazard ratios here for whatever reason. This was a planned analysis, but it has never actually been statistically verified. I have begged Eli Lilly to do that. Unfortunately, that has not happened. So it really leaves us wondering, is this a real benefit or is it an illusion? So I put the two trials side by side, the two that have actually looked at PEM-Bev versus Bev alone, and we see fairly consistent findings. On the bottom, about a 2 to 3.5 month improvement in PFS, again, a 2 to 3.5 month increase in overall survival, suggesting perhaps a benefit for combination maintenance. This will ultimately be decided by ECOG 5508. So 4 cycles of PAC carbo Bev up front in the absence of progression, standard continuation maintenance with Bev, switch maintenance with PEM, or a hybrid of the two. This trial has completed accrual, and I suspect we'll see the results hopefully in the next 6 to 12 months. And this trial will really determine how we practice. If we see no survival advantage for the combo versus single agents, we will, even though many of us really like giving the PEM-Bev maintenance, we'll probably have to pick one or the other. AVA-ALL is a phase 3 trial testing the notion that Bev can be continued beyond progression. Remember, in colorectal cancer, there's a survival advantage for Bev beyond progression. This is testing the same issue. Stage 3B and 4 non-squamous treated with a platinum doublet and bevacizumab for 4 to 6 cycles who've gone on to maintenance at least 2 cycles or more, and then at the time of disease progression go on to standard second-line treatment or standard second-line plus Bev continuation. And this can be continued through the 3rd and 4th lines of treatment. This trial was slated to accrue 600 individuals. I think it has about 550. It's completed its accrual about 8 or 9 months ago, and I think this trial too will probably see the light of day in the next 6 to 12 months. And one of you actually asked about this. I don't think we covered this necessarily during the first sessions. What about Bev and Earl in combination? So in mutant-positive non-small cell, this has been tested in Japan with activating mutations. So erlotinib alone or the combination of Bev and Earl, and we see a 6.5-month improvement in median progression-free survival, hazard ratio of 0.54, very impressive p-value. Overall survival still very early, and there are other trials around the world that are attempting to duplicate this. This is interesting. It's like a, good Lord. We seem to have a pile-on of, there we go. It's sort of an accumulating of data, and it just sort of builds up in your brain. So, so Ramucirumab is a recombinant human IgG1 monoclonal that binds, remember, the extracellular domain of VEGF receptor 2. It blocks the receptor, not the ligand. The REVEL trial was a phase 3 looking at second-line docetaxel after platinum-based treatment with or without ramucirumab. A huge trial, over 1,200 patients. In the interest of full disclosure, I was on the Data Safety Monitoring Committee for this trial. You can see over a quarter had squamous histology. And we do see a significant improvement for response rate, for progression-free survival, for overall survival. The p-values are shown there. They're fairly impressive. This is the first study in second-line non-small cell to show survival benefit versus docetaxel alone, and the first study I'm aware of to show any benefit for angiogenesis inhibition in squamous cell. Remember, they had been excluded from the Bevacizumab trials. So statistically significant, many would argue, clinically modest improvement in overall survival, but nevertheless a clear benefit. When we look at toxicity, there is a bit more neutropenia and febrile neutropenia, fatigue, but no difference in the incidence of grade 5 events, and really no significant difference in pulmonary hemorrhage. Remember, those with central lesions wrapping around vital vascular structures were excluded from this study. Finally, TKIs. The therapeutic landscape, or should I say the therapeutic battlefield, is littered with the carcasses of drugs that have never made it to the light of day in this realm. Many of these are approved for other uses, but not in non-small cell. Nearly 10,000 patients accrued to these efforts over a 12-year period. All of these studies, with one exception, have been negative. And we've really speculated why these studies have failed. It's the absence of tissue markers or predictive polymorphism, inadequate doses of the experimental agents. I doubt that, since we certainly cause toxicity. Maybe the TKIs and the vascular disrupting agents don't play all that well with chemotherapy platforms. I certainly subscribe to that to some extent. And it may just be a flawed concept that the tumor itself eclipses its microenvironment, and we really need to target the tumor, although certainly our experience with immunotherapy, as you'll hear this afternoon, would put the lie to that. There is one exception, and that's nintedanib. So this is a versatile, some would call it a dirty TKI, since it targets not just VEGF, but fibroblast growth factor receptor, PGFR, as well as RET. No overt drug-drug interactions, and single agent has actually shown some activity in recurrent non-small cell. So LUM-1 was a prospective randomized double-blind phase 3. Again, docetaxel backbone plus or minus nintedanib. You can see the doses here. This was an oral agent. 95% had prior platinum exposure, and 5% actually had prior bevacizumab exposure. The data are shown here. Significant improvement in PFS, which unfortunately did not translate into an overall survival advantage, but in the adenocarcinoma cohort, which is really more than 50% of the patients, you do in fact see a survival benefit with a p-value of 0.036. You also see more toxicity, certainly diarrhea, transaminitis, some rash. So significant improvement in PFS, manageable AEs, no overall survival advantage with the exception of adenocarcinoma. Intriguingly, preferential benefits in those with platinum refractory disease, and really insufficient data on those with Bev exposed. So were these data sufficient to get this agent approved in the second-line setting? Not in North America, but yes in Europe. And so this agent is in fact available in second-line in Europe. And of course, it's restricted to adenocarcinoma. The attempts to duplicate this study in the US were unfortunately failed, or at least were aborted. So my conclusions are shown here. I'm a little over time, I apologize, but Bev is the first targeted agent approved for frontline use in advanced non-small cell in combination with Pac-Carbo. That's still on the package insert. Non-squamous histology, no antecedent hemoptysis or untreated brain mets. Certainly if they've been treated and they're stable, patients are reasonable candidates. The Beyond trial, which most of you are probably not familiar with, confirms ECOG 4599. There may or may not be benefit as maintenance. I suspect there is. There is no benefit in the adjuvant setting. Tracy showed you the data yesterday. Ramucirumab is the first monoclonal targeting angiogenesis to show survival benefit in the second-line setting, specifically in combination with docetaxel, and the first to benefit squamous histology, and nintedanib is the only TKI targeting angiogenesis I'm aware of to show potential survival benefit, and again, restricted to adeno. So with that, you've seen everything you need to know about angiogenesis inhibition in non-small cell.